So let me share the screen. Please let me know if you are able to see it. Is it visible to everyone? Hello?
Yes, sir.
Yes,
Yes,
it is
it's
visible.
visible.
I cannot see that whether it is visible to you or not. Okay. So let's start with the first acromioclavicular joint arthritis. As I have told, acromioclavicular joint arthritis is more commoner than a glenohumeral joint arthritis. And here the pain is in the anterior part of the shoulder and slightly at the top. Now, it can happen because of normal wear and tear with time of or repetitive stress, that is actually the degenerative, or it can be the result of trauma or injury to the shoulder. Now, first, it is the degenerative. As I told, the most common is older than 40 years of age. Post injury, which can happen at any age, but with repeated dislocation, the chance is more, and repetitive stress like weightlifting, overhead sports, javelin throwing. So, these can also give rise to this condition. Now, if you look at the symptoms, the pain will be at this point. That means it is the localized pain. If you just palpate your spine, then your acromion, and then it is clavicle. So in this junction lies the acromioclavicular joint. So sometimes there will be pain, there will be swelling over this bony prominence. And one of the clinical tests asks the patient to put the shoulder cross arm. So whenever we are putting the shoulder cross arm, you can think that here will be more pressure and that will increase the pain for the acromioclavicular joint pain. And clinical examination also includes the cross arm adduction and then palpation of the acromioclavicular joint and compression with the opposite shoulder. So let's see how the acromioclavicular joint looks under ultrasound. But here is a practical tip, especially for the beginners. Whenever you are searching for the acromioclavicular joint, don't search from the anterior side, because if you look at the joint, the anterior up and down spread of the joint is very less, whereas at the top you will be getting more space for the joint. So always start searching from the top of the acromioclavicular joint. So Dr. I will be showing the acromioclavicular joint. Please come. So first you see the scanning and then I will show the injection technique. Please share the screen.
Okay. So acromioclavicular joint, patient's hand can be in the neutral position only. We are not seeing from the front side of the shoulder. We will be seeing from the upper part of the superior part of the shoulder joint. Okay. So here how will you do? First we will palpate the clavicle. I am coming laterally. Here I can find a gap. I can palpate a gap. But of course, if you don't palpate also, then also you can put the probe in this way. Here I am putting the probe in this way. So if you just, I put the probe in this way directly.
It is not visible.
The ultrasound image is not showing up.
Visible, not visible. Okay.
Just a minute.
Okay, now it is visible. So please continue. But it's good. This is perfect.
Okay. Okay.
I'm just hiding the sources.
Okay.
I think you can see now.
Yes, we can see now.
So
Sir,
we can see. Yeah.
Yes, it is visible.
So this is the acromioclavicular joint. You can see how I have put the probe in this way, and then the thing is that which side is acromion and which side is clavicle. So here, if I go like this, I can see that this bone is ending laterally. So this that means right side bone is the acromion and this side is the clavicle. So here, if I pull it like this.
Orientation marker on the screen, sir. That's
Yes, left side is usually the index marker we mostly keep at the left side.
Just a minute. This long preview. Medial, lateral, acromion, clavicle. This is a joint capsule. This is a joint capsule. Okay. We can sometimes see the humeral head also in this area. Mainly the supraspinatus muscle bulk. Mainly the supraspinatus muscle bulk. Sometimes we can see, sometimes we cannot see. Okay.
Just you can show one thing, like from the anterior, how it is difficult to find out, because that is also very important. See, the standard way is from seeing at the top. But sometimes if you want to see in the anterior side, see how difficult to find out the joint is. So you will be getting it, but it's a very small area.
So this is the area.
Yes.
Okay.
So
But
it's comparatively difficult to get it. But
so,
just put from the top, the joint is very easily visible. And you can go here either under the in plane view, or you can go an off plane view as well, because this joint space is very small and it is very superficial. So sometimes it might happen, it may be a little difficult. So if you can go from the top side, so what you can go, you can just choose an out of plane approach. But sometimes if the joint is inflamed, then you sometimes you can go for the in plane approach as well. But in most cases, out of plane is comparatively easier than the in plane approach. Okay, so I think you have seen the normal acromioclavicular joint. So let's show you the abnormal. So here is the abnormal acromioclavicular joint. See, the whole joint is inflamed here. This type of inflammation is there. The margins are irregular. Sometimes bony projections can also be visible. And sometimes what happens if you, especially for the subacute and acute cases, if you switch on the color Doppler, you will be able to see the hyperemia in the local site as well. So if it is such an inflamed joint, then definitely in-plane is also possible. But in most of the cases, if the joint is not so much inflamed, then you have to actually go for the out of plane approach. So treatment, the standard treatment is definitely first the RISE therapy. That means rest, activity modification, give a course of NSAIDs, start the physical therapy. If it is responding, well and good. If it is not responding, then go for the intra-articular corticosteroid injection, which actually the result is temporarily. But remember, as the inflammation is dying out and the pain cycle is broken, sometimes this can give a very prolonged pain relief, unlike the standard case of steroids, where the relief is temporary. So let's see the injection at the acromioclavicular joint. So while we are injecting at the out of plane approach, you won't be able to see the whole needle. Rather, you will be able to see the needle only as a small point. So patient position here is seated. In old age patients who are prone of developing the vasovagal, do in a lie down posture. Transducer should be put from the top, and the needle orientation inject using out of plane technique for most of the joints. So we are expecting, so here we'll be putting our needle. Now see, here is the needle. So once you can see the needle within the joint, just at the tip of my cursor, you can see the needle, and you just have to find out the tip whether it is inside. Because what happens whenever you are doing any procedure in out of plane approach, you have to locate your needle tip. That is most important thing. So within the joint, we should move and we should find out that the needle is vanishing within the joint, and if you go slightly posterior, the needle is coming. That means the needle tip is inside the joint. Once you have confirmed the needle tip within the joint, then we should inject the local anesthetic steroid mixture. Especially for the out of plane approach, if you are seeing the needle within joint, that is not sufficient, you go anterior and posterior, so that you have to establish that the needle tip is exactly in the joint. That means within the joint level, your needle tip is ending as well. That is very, very important whenever doing any out of plane approach procedure. So hope you have understood. Here we have done the in an out of plane approach. Okay. Next, coming to the adhesive capsulitis. This is one of the very common pathology affecting a number of individuals, especially those with diabetes, especially those with old age, especially those with post-trauma, sometimes with the post-surgery. So these patients sometimes can develop inflamed capsules of the joint. And this disease goes like a cycle-like manner. That means initially there will be development of pain, then the capsules adhere to one another. Ultimately, initially the most predominant feature remains the pain. As the disease progresses, usually the pain usually settles down, then the restriction of movement sets in. So then after that, so initially the phase of pain, then phase of stiffness or the frozen stage, and then goes to the thawing stage. And approximate duration of this whole cycle of frozen shoulder remains almost 2 years, and it is very debilitating for the patients, especially for the diabetes. It can develop multiple times. So three stage: first is freezing stage, gradual onset of pain, then progressive loss of range of motion, followed by frozen stage where the pain reduces, stiffness prevails, and then slow improvement and the range of motion improves over time. So altogether it can take 12 to 42 months. Now with the treatment you can reduce it, and actually you can give a more functional shoulder for the patient. Now medical conditions, I have already told, diabetes is one of the most common cause what we found in a number of diabetics, and those patients you cannot give steroid too much as well. Intraarticular small amount may be given, but not too much. Definitely it will actually put the control even further bad. Next is a thyroid dysfunction, prolonged immobilization because of the injury or surgery, and sometimes occur without a clear reason, that is known as the idiopathic.
Sir,
If you
can you show the previous slide once? My net
yes,
got disconnected.
which one? This one?
Yes, sir. Yes, sir.
Okay, you can take a
Right.
picture.
Okay, sir.
Okay, and also you can stop in the recording and you can check once more. Okay. So actually this I have already described, and you can see this. Okay, and this is a very common scenario of the frozen shoulder. It is very common. So pain, stiffness, and definitely functional limitation, they are the main problems. Clinical assessment, definitely. One of the shoulder evaluation tips is you have to find out where the active is impaired and passive movement is impaired. Remember, whenever the pathology is related to the muscle, for example, rotator cuff muscles, then you will find there is a distinct difference between the active movement pain and the passive movement pain. Or wherever there is a capsule problem and a glenohumeral joint problem, in those cases, there is a distinct difference between the active and passive movement. So what is the difference? What happens whenever the joint and capsule is involved? In those cases, both active and passive movements becomes painful, or sometimes both are not possible. Whereas in case of rotator cuff disorders, what happens? If the rotator cuff muscles of one side is involved, here what happens? Number one, when the patient is moving actively, the pain is more. The problem is more. If you are doing it passively, the problem is less. And it is also directional. Suppose one rotator cuff supraspinatus is involved. Then what happens? Whenever I am putting the shoulder over the arm, hey, that is painful. But whenever I am doing an external rotation, that is the most of the action of the teres minor and the infraspinatus, that will not be impaired. So there is a directional difference in between a rotator cuff tenderness and a shoulder joint problem or adhesive capsulitis. In adhesive capsulitis and glenohumeral arthritis, usually what happens is the whole shoulder gets involved. So both active and passive is usually involved. Now this picture is very, very important in the part of treatment options, because previously in previously in adhesive capsulitis or frozen shoulder, what is the common treatment we used to do? And block with the nerves. Then our main aim was that time to reduce the movement, to block the nerves, to reduce the pain and improve the physiotherapy ability, so that the patient can exercise better and the treatment can go smoothly. But I think last 10 years, this is one of the most important treatment is the shoulder joint hydrodilatation. Okay. Remember, previously, you also have done the movement under a general anesthesia. That is also an excellent treatment. I am not going against it. But even without the risk of general anesthesia, just by giving shoulder hydrodilatation, nowadays this can be treated without any general anesthesia and without those risks as well. And this technique is known as the rotator cuff interval injection or the hydrodilatation through the anterior approach. Now, what is rotator cuff interval? I am just saying in a simple word, remember one muscle that comes from within the shoulder joint. This muscle is the long head of the biceps tendon. So here the long head of biceps tendon from the supraglenoid tubercle, it is coming and going out through the intratubercular sulcus. That means in between the greater tuberosity and lesser tuberosity. Now what happens to the synovial membrane? Remember, this is a picture from inside the shoulder joint towards the long head of biceps going out. So what we can see, around the biceps tendon, the synovial sheath also goes out. So just look at the small picture on the left side, then it will be clear that how this rotator cuff interval is formed. So along the biceps tendon, there is a space which can directly go into the rotator cuff interval, or it can actually go within the shoulder joint. Now the question is, what are the structures surrounding it? So see what are the structures surrounding it. So here lies the long head of the biceps. In this side, we have the supraspinatus. In this side, we have the subscapularis. So in between these two muscles, that means the supraspinatus and subscapularis, there is the biceps going, and there is also the synovial recess coming out. And just above the synovial recess, we have the coracoid process to humerus ligament that is known as the coracohumeral ligament. And along with the shoulder joint capsule, this coracohumeral ligament, superior glenohumeral ligament, middle, inferior. So these glenohumeral ligaments are also getting more tense and they are also becoming more hyperechoic. So previously, when the shoulder hydrodilatation was started, it was the main hydrodilatation from the posterior side of the glenohumeral joint. But main pathology remains in the anterior side, in the coracohumeral ligament, in superior glenohumeral ligament. So what happens? They becomes very tough, and that is why external rotation in adhesive capsulitis becomes too difficult. Now, if we can approach in a space which is close to the long head of the biceps, what we can do, we can stretch that area with the fluid, and it's not small volume. Usually 20 to 40 ml of fluid is injected into the rotator cuff interval by the side of the biceps under the coracohumeral ligament and close to the superior glenohumeral ligament, or close to the, you can go either the side, either medial or lateral side, that's not a problem. There are studies that have shown medial is slightly better, but definitely you can go under the long head of biceps to the area in this recess. And then if we inject in the frozen shoulder patient, so that will stretch and dilate the structures. And that also improves the movement for those patients. So this picture is very, very important. You can see in one side, it is the supraspinatus. In other side, it is the subscapularis. So it is the superior part. This is the inferior part of the shoulder. And here we are having the coracohumeral ligament at the top, one fold that the superior glenohumeral ligament at the bottom, middle glenohumeral line slightly lower. And in this area, if we go just by the side of the long head of biceps tendon and inject, that will stretch the shoulder and that will help the patient. And that is the main aim behind doing such a procedure, and this is one of the very successful procedure. So let's see how rotator cuff interval looks under ultrasound.
Excuse me, sir.
Yes.
For these injections, we prefer for patients who are diabetic or any person, any non-diabetics also.
Yes, for both the patients. Diabetics are more prone to develop the adhesive capsulitis, but it is not that fact that other patients cannot develop. Okay. So other
Uh,
patients can also develop the adhesive capsulitis. In those cases, it can also be done.
for no, those who do not have diabetes, can we give steroid in them, sir? Actually,
Yes, even with the patients who have diabetics with a good control, you can give steroids in them as well. But remember, there are few things which has been tried for the rotator cuff interval injection. One of them is definitely the local anesthetic steroid and normal saline mixture. The other is definitely the 5% dextrose, and it has been found both works in in it. Okay, there are some
Okay.
studies which shows 5% dextrose is slightly better, but in my experience, I have not found much difference. But definitely studies are there.
Okay. Okay,
Okay.
sir. Thank you, sir.
Okay, I show you that under ultrasound, the location of the rotator cuff interval under ultrasound.
What is the volume, sir? 5% dextrose in local and steroid dose.
Volume is the same. It is in between 20 to 40 ml. In most cases, we go around 30 to 35.
Okay. Steroid dose, sir, 40 mg.
40 mg is more than enough. Okay.
Okay.
And
sir.
but before stretching, just inject little bit local anesthetic. Okay. Usually
Okay, sir.
inject 3 to 4 ml local anesthetic, 1%. Then I start dilatation because otherwise pain will be too much.
Okay, sir.
Okay, I show you the location of the rotator cuff interval. So subscapularis is coming like this. Okay, from this side, medial side, it is coming like this up to the lesser trochanter, lesser tuberosity. Then supraspinatus is coming like this, and it is coming up to here. That is the greater tuberosity. Okay, so between subscapularis and supraspinatus, there is a gap, and this gap is interval, rotator cuff interval. And if we puncture here, the medicine will go inside the capsule. So let us see the gap. So if I put the probe in this way, so actually what I am seeing, okay, so first I will put the probe like this. Here left side is medial side. Okay, left side is medial side. Just please go to, okay, okay. So here just I show you. So this is step 1. Okay, step 1 to see the rotator cuff interval. So this is the medial side, this is the lesser tuberosity, this is the bicipital groove, and of course this is the greater tuberosity. Now what is this part? This part is subscapularis, and this part is biceps tendon, Now after seeing first step, I am showing you the second step. So all the steps are for seeing the rotator cuff interval. So what I did, I came from above like this and I stayed here to see the first step. Okay, this was first step. Now what I will do, this lateral side, I will just do like this. It is an angulated manner. I am just doing like this. This is second step. Okay, so freeze, just freeze. Yeah. So now this second step, what it shows again lesser tuberosity, subscap. This side, what it shows, supraspinatus. This side, biceps, long head of biceps. Okay, long head biceps tendon. So this now as we have understood this one, now understand this subscapularis we are seeing in long axis, whereas supraspinatus we are seeing in short axis. Now understand that how this thing is possible. So I am holding like this. Since this tendon supraspinatus is coming like this, then supraspinatus is in short axis, but from this side your subscapularis is coming, that's why it is in long axis. Okay, so this is the rotator cuff interval. Now let us see the structures a bit better. Okay, so I am decreasing the depth. So this is the first step, this is the second step, and this is the third step. Third step is just doing like this, like coming up and doing like this. So this is the third step. So here I'm seeing a only limited area. Okay, so in this area, okay, just freeze. Okay, okay. So in this area, remember this side, lateral side, supraspinatus. This side, medial side, subscap. Here long head of biceps tendon. then the whole area is not biceps tendon, only a part. Okay, then what is there in other part? So this side is nothing but glenohumeral ligament, which is the recess part. Okay, and there is one more thing, one more ligament that is coming like this. Okay, this white part, this white part. So this is called coracohumeral ligament. Remember, this upper ligament is actually coming and joining here also. Some fibers are here also. Okay, so that is different thing. So just remember, this part is coracohumeral ligament and this part is glenohumeral ligament. So your needle will come at two places. Either it can come from here to here for injection, or it can come from medial side to here also for injection. This area is both the area actually injection, the drug will go in the recess. Okay, so just see again. So first step, second step, and third step. So this is the recess. So I think you can see clearly. Okay, just freeze. Okay, okay. So I think everyone can see that this part and the adjacent part is not same. This adjacent part is different. Okay, upper this part is different. So anyone can say what is the green arrow? What is what I am showing?
Jesus.
Gleno, ligament,
Gleno, glenohumeral
glenohumeral ligament.
SGH.
Glenohumeral.
superior glenohumeral ligament. And this part, what is this? This white color. This white color.
Coracohumeral ligament.
Coracohumeral ligament. Okay, just remember the orientation. Huh? This one is in short axis, this one in long axis. This is
Long.
subscapularis, this is supraspinatus. So for injection purpose, there are two areas. One is here and one is just by the side of the tendon. Both the areas injection will go inside the joint.
Okay, so you have seen the normal coracohumeral ligament. So it's time to see an abnormal coracohumeral ligament. So let's see the abnormal coracohumeral ligament. So in this picture, you can see an abnormal and more hyperechoic coracohumeral ligament at this point because of the adhesive capsulitis. Now, I have already told you about the treatments. So basically, we are going to go for a distension arthrography for the adhesive capsulitis or frozen shoulder. So it is has to break up the adhesions and reduce the capsular tightness. So how the needle is injected? So here you can see we are putting the needle close to the biceps tendon. Biceps tendon is at this point. So now you can see at this point is the biceps tendon. Okay, so it depends on the steepness. It is a comparatively steep, so we cannot see the needle that good, but we have to put just by the side. We see here is a tendon just by the side we have reached, and then we'll start injecting and we'll start the distension. And one of the most common tip, I think everyone knows that whenever you are not able to see the needle properly, you rotate the needle. So here I am actually rotating it to see the needle a little better with the tissue movement. Okay.
So I have a doubt.
Yes.
So for these blocks, what length needle should we be using?
It depends. In most of the patients, normal spinal needle is good enough. If you want a better needle, then you can choose a echogenic spinal needle of a very good company. There are a lot of companies, but some echogenic spinal needles are basically bogus. It doesn't increase echogenicity. But Stimuplex is a good one. So you can go for a Stimuplex, that is if you have, or otherwise we can use a normal size Twinkie needle because the structure is not very deep.
Okay, sir. Thank you, sir.
Okay. So once we have reached at that area, then we'll be injecting the, sure, it will take time and you will see the CHL will move up. Once we start injecting, okay, So it takes a little time. We are injecting for long. Now you see fluid around is also increased. Okay, and then we'll check from the different angles that it is going perfectly within the joint. See, now this portion is comparatively distended after giving the injection. So
Can we combine the, excuse
yes,
me,
yes.
can we combine the dextrose with the steroid
Yes, I
with
have shown
Devo?
you that studies are there, and some shows the long-term benefit with the dextrose is comparatively better than steroids. Okay, that type of study is also there. But remember, these are isolated studies, so unless and until we are getting a big review or a meta-analysis, it is very difficult to comment. Okay, because both of the things are practiced. Okay, it is not that one part is practiced, the other is not. Okay,
So
so
can we
currently I
combine
use most of the cases, if it is diabetic, then also only I use dextrose. Otherwise, in most of the cases till today, I prefer giving a little bit local anesthetic followed by normal saline in a small amount of steroid. Okay, but yes, in some people I have used dextrose also. It also works good. But the initial pain sometimes might happen a little more with the dextrose than the this steroid injection. Okay,
So total, how much ml should we inject?
just I have told in between 20 to 40. In most cases, we give around 30 ml of injection.
Okay.
Okay, and this is a very rewarding procedure. Why we are repeating it again and again? It's a very good thing because previously even we have done the manipulation under anesthesia, but nowadays it is rarely required because of this shoulder hydrodilatation, which we are actually sometimes may have to repeat 1 2 times, and it gives a very good result. Now, one part I have skipped from the anterior part is the subscapularis and the subcoracoid bursitis. So last day we also missed this part. So I am going into first into the subscapularis anatomy that I have shown in the last day. You can remember it is coming from the anterior side of the scapula and getting attached with the lesser tuberosity. So here lies the subscapularis muscle. So what pathologies might happen in subscapularis? Same as the supraspinatus. Can anyone tell what are the common pathologies of the supraspinatus that we have seen?
Sir, calcific tendinitis,
One is calcific tendinitis, one is normal tendinitis without calcification. Next,
bursitis,
yes, close to if there is any bursa. Here we are having close subcoracoid bursa. So here we can have the subcoracoid bursitis. And any other pathology you can think of?
tear,
Yes, partial or complete tear, same here. Subscapularis can go same type of things, but depending on the position, as it is at the medial side and it helps in the this movement, that means adduction movement. So the problems in these movements. So what will be there? So there will be anterior shoulder pain, there will be weakness, sometimes there will be clicking or catching, and sometimes there could be instability. And any movement that is associated with it. So what are those movement associated? One you can think of is a belly press test and one is lift off test. They are similar principles. So what is lift off? Just ask the patient to put like this and then lift the hand from the back. So from here he has to lift the hand, and in this position also we need to use the subscapularis power. Similarly, if they ask the patient to press the belly. So normally the hand will be here and he will be pressing normally. But if the subscapular is impaired, then the patient will move and then he will try to move with the palm. So instead of using the subscapularis, we will try to move with the other muscles. So these are the two common tests that known as the lift off test. When we are lifting off from the back, again this requires subscapularis power to lift, and also the belly press test. Here also it will be a little bit difficult when there is subscapularis problem. And subcoracoid bursitis, it is just under the coracoid close to the subscapularis. So fluid might accumulate in the subcoracoid area, and this is known as the subcoracoid impingement, similar to the SSD bursa and impingement syndrome, that is the subacromial impingement. Here also we can have subcoracoid impingement. So Chinmada, please show the subscapularis and the impingement, the subcoracoid impingement that we have not shown in the last day.
sir, I have a out of context question, sir.
I think we can take it later because today now we have to cover everything. So at the end we will be taking.
Okay,
So
sir.
the whole
Thank you.
posterior part till we are doing with the last day's class.
Okay, sir. Thank you.
So I'm showing you the subcoracoid impingement or subcoracoid bursitis area. So this is the same way how we see the subscapularis. So here we are seeing the lesser tuberosity and subscapularis. So left side it is the lesser tuberosity, and then we are seeing the subscapularis which is inserting there. Now I am going a bit medially. So if I go directly a bit medially, I am seeing actually the coracobrachialis. So I am going a bit up also. So now I am seeing the coracoid process, and I am seeing the lesser tuberosity also. So this is the area. Okay, sure, freeze. So this one, this part is the coracoid process. This is the subscap. This is the lesser tuberosity bone. Of course, this part is biceps tendon. Okay. Now, as I already told you the last day that when there is a subacromial impingement, that means when he wants to abduct this arm, this greater tuberosity enters under the acromion and then can be a rubbing. Similarly, when he does the internal rotation like this, internal rotation, then lesser tuberosity can go under the coracoid and there can be a rubbing. So that is the point where that is the cause of subacromial impingement. So see how it rubs. Subcoracoid impingement. Okay. So here see the whole thing is under the coracoid, lesser tuberosity. It has, I am showing you. So
in left side, you can see the coracoid process. In right side, it is the subscapularis. Okay, now with the internal rotation, the subscapularis is actually moving under the coracoid.
So he has done completely internal rotation, but still there is a lot of gap between the coracoid process and lesser tuberosity. But in some patient where there is a impingement syndrome, these two bony structure can impinge the subscapularis tendon in between. Okay, here there is a lot of gap. Okay, so you can see a lot of gap is there between these two bony structures. Now, abar ghora bhitor dike. Okay, so এই জায়গাটাতে freeze কর. Just a minute. Okay.
Okay, so whenever you want to check those patients with the subcoracoid impingement and anterior pain, so in those case, we will be actually going and checking the internal rotation, whether it is going properly inside the coracoid tendon or not.
So this is the gap. This much is gap is there, but this gap could have been smaller, and this tendon could have been impinged between these two structures, these two bones. Okay, so then it will be a case of
Also, here could be one bursal fluid, okay, under the coracoid. So that is the subcoracoid bursitis.
under the coracoid, above the subscapularis.
Okay, in between the coracoid and subscapularis, there will be accumulation of the fluid. So let us see the pathological slides. So we have seen the normal one. Now it's time for the pathological one. Okay. So in this picture, we can see the tendinosis and tear of the subscapularis. The pathology, everything, it will be like the supraspinatus. They are not different, but only different is the tendon. It is in the subscapularis tendon. Similarly, if there is partial tear, we will be able to see the gap or the black area within it, and partial tears responds very well with the platelet-rich plasma injection. Whereas if it is a full thickness tear, sometimes see it is a full thickness tear with the accumulation of fluid, the hole from the lesser tuberosity, this part is actually completely detached, and in between, because of the trauma, inflammatory fluid is accumulated. So basically it's a complete tear of the subscapularis tear, and this needs definitely a surgery for fixation. This is a subscapularis calcification. So last day I have told you about the grades of calcification. So what grade of calcification it is? Usually it is the grade 2 calcification because the classic acoustic shadow underneath is not there, but the calcifications are dense and you can see the hyperechoic spots within this subscapularis muscle. So it's clear the subscapularis calcific tendinopathy. Here is a case of subcoracoid bursitis. Okay, so here you can see the fluid filled bursa just by the side of the coracoid, and in between this is the subscapularis. In between the subscapularis and coracoid, you can see the fluid filled bursa, and it is the subcoracoid bursa. Okay, so with this, we should end the anterior shoulder part and we'll be moving to the posterior shoulder part today. So let's start with the posterior shoulder. So before going into the presentation, let's first share and let's first try to find out the anatomy, because understanding the posterior shoulder anatomy is also important to understand the posterior shoulder properly. So let's go for the posterior shoulder anatomy, and for the anatomy definitely best is the 3D map, so you can see all the structures in a beautiful way. So previously we was looking at the anterior shoulder. We have found the AC joint, we have found the coracoid process, acromion and everything. So if you come to the posterior side, you see the acromion is moving back and ultimately it is getting fused with the spine of the scapula. And if you look above, just above the spine of the scapula, there is a fossa. This is known as the supraspinatus fossa. And there is also a notch. This is known as the subscapular notch. And there is a ligament which is known as the transverse scapular ligament. It is not shown here because it's only the bone. So one of the thing that we have to evaluate, we have already shown in the last day, here at this point is the muscle of the subscapularis, sorry, supraspinatus, that remains at this point. And we'll be today learning this area also, because the nerve supply of both the nerves, both the muscles, that is the supraspinatus and infraspinatus, which remains in the infraspinatus fossa, they are being done by this subscapular nerve. So I will come to the nerve later, but we should understand this anatomy. So above here we are having the subscapular notch, here we are having the supraspinatus fossa, here we are having the infraspinatus fossa, here we are having the joint, here ends the bony glenoid cavity. But after this bony glenoid, it is not ending here, because there is the cartilaginous labrum in the posterior side, and sometimes this labrum can be associated with the pathology, especially in cases of injury or especially in cases of osteoarthritis of the glenohumeral joint. And there is a notch at this point as well. So here also we can see a notch at this point, and this notch is known as the spinoglenoid notch. There is a huge significance of this notch, and nowadays we do our interventions close to this notch. I will come to later, but before it, let us see the muscles and then we'll be seeing the nerves. So one by one, let's go for the next structure. So we have first seen the bone, and then we'll be going back and we'll try to find out the other ligaments and muscles. So if we look closely in posterior part, as I told, there is one ligament here. This is known as the superior transverse scapular ligament. This ligament we can see under ultrasound, and under this ligament the classic suprascapular nerve block is being done in most of the cases. Here remains the tendon of the supraspinatus muscle, that is obvious, and at this point we are having the inferior transverse scapular ligament, and here we are having the spinoglenoid notch. Just by the side we are having the joint capsule, and if we hide the capsule, then we are having the labrum at this point. This is the glenoid labrum. So we have understood the bones and the ligaments, and third part we'll be understanding the muscles. So if you go at the posterior part, the deltoid, as I told, it is covering the whole of the structures, and under the deltoid, if you hide the deltoid, then we can see the other structures. So from the posterior side, we are having this muscle. This is the infraspinatus, which is attached to the, again with the greater tuberosity, This is the supraspinatus. Okay, and just below it we are having the fourth rotator cuff muscle, which is known as the teres minor, and even below we are having the teres major muscle. Remember, teres minor is a part of the rotator cuff muscles, but teres major is not a part of the rotator cuff muscles. Teres minor attached at the greater tuberosity, but teres major goes towards the anterior side and it attaches close to the in the middle lower part of the humerus. And posteriorly, there is one important muscle with its three attachments. This is known as the triceps. Here lies the medial attachment which goes under these muscles, and this attaches with the infraglenoid tubercle. So this muscle is important. And then we are having the lateral head here, and if we go at this side we are having another head of this muscle. Okay, that is the medial head of the triceps. So basically it is known as the triceps because it has three heads. We are having the medial head, which is remaining one side of the radial groove, a medial side of the radial groove, then lateral head, which remains at the lateral side of the radial groove, and the third head, it is known as the long head. It attaches with the scapula, with the infraglenoid tubercle of the scapula. So we have understood all these muscles. So this is the teres major. Now it is the infraspinatus, and this muscle is the teres minor. So we have understood the muscles. So after the muscles, we have to understand the nerves as well. I'm going a little fast, but I think it is comprehensive. But anyone is having any difficulty in understanding, please stop me and ask. Otherwise, it is not possible for me to understand that whether you are able to understand or not. Now, again, this is a picture with the nerves. So first we are hiding the deltoid. So here we are showing the important nerves. So in posterior part, we have few important nerves that is very important. This is a not that important. That's the lateral supraclavicular nerve that is again coming from the which plexus? Superior cervical plexus. That's a branch of the superior cervical plexus. Cervical plexus basically. Here lies the supraspinatus, and if you hide the supraspinatus, below you can see this important nerve. There is the subscapularis nerve. So subscapularis is one of the important supply of the shoulder joint. So I have told in previous days, in most cases we used to block the suprascapular nerve. Remember, this suprascapular nerve have motor branches as well as the sensory branches to the shoulder joint. So it gives motor branch to the supraspinatus as well as the infraspinatus. So let us hide the infraspinatus. So after coming out under the transverse scapular ligament, it's supplied to the supraspinatus muscle. Then it goes to the spinoglenoid notch. Then it gives a branch to the which muscle is this? Infraspinatus. And then it gives pure genicular branch. So previously, when we used to block at this point, remember, if we block with the local anesthetic, it is fine, no issues, because it is not going to give you a motor weakness. But if
So
you want
is
to
it
get relief,
subscapular or supraspinatus nerve?
which one? It is
The
always,
nerve.
remember, supraspinatus nerve is not there. It is always subscapular.
Ah,
That's
so
supplying the supraspinatus as well as the infraspinatus. Okay.
okay, sir.
So it is the it is mainly the suprascapular nerve. Sorry, there is nothing called the subscapular nerve. Okay, it is a suprascapular nerve. It is supplying the supraspinatus and the infraspinatus. Okay, so first branch giving it's the muscular branch to the supraspinatus, and then it is giving a muscular branch to the infraspinatus. Then in the spinoglenoid notch, slightly laterally, close to the joint, it becomes a purely sensory nerve. So that is the advantage. Nowadays, instead of targeting at this point, we target here, and at this point we can do a cooled radio frequency, we can do a conventional radio frequency. Cooled is preferred because in every time the nerve cannot be visible clearly, and it is always associated with the suprascapular artery. So artery becomes one guide for us. Okay, so this is one nerve you need to know in the shoulder and know very well, so that you can block this nerve at the perfect location and perfectly. So here, if you block, there will not be weakness of this muscle, neither the supraspinatus or infraspinatus, but it will block the pain originating from the shoulder joint. So in certain cases where surgery is not possible, we have to go for a shoulder block, shoulder denervation. We can block at this point of this nerve. Now there is another important point in the shoulder in the nervous point of view is this one. So what is this nerve originating? This is the axillary nerve, and this branches of axillary nerve remains in the quadrangular space. So what is the quadrangular space? So let us see the four, basically three muscles, but four bellies. They are forming two small triangular spaces and one quadrangular space. So here lies the teres minor, here lies the teres major. Through, if you look at the posterior side, superficial to the teres major passes the long head of the triceps. Then it goes underneath the teres major to getting attached with the infraglenoid tubercle. Whereas the lateral head remains close to the humerus. So in between these two area, that means if you see the quadrangular space, above it is bounded by the teres minor, below it is bounded by the teres major. If you look at towards the medial side, it is bounded by the long head of the triceps. If you look at the lateral side, it is bounded by the lateral head of the triceps. And in between, I am just hiding the cutaneous nerves. Okay, so these are actually all cutaneous nerves. Here we are having one important nerve, that is the axillary nerve. So if you have to block these branches of the axillary nerve, we have to come to the quadrangular space, and then here along with one artery is there, that is the circumflex humeral artery. So close to that artery we will be able to see the branches of the axillary nerve. Sometimes one branch, sometimes it is already divided, so 2-3 branches might be seen close to it, and we have to block at this point. So here we can block the axillary nerve. Here also coming the point that if you are only want to block the sensory, you won't be able to block here, then we have to block close to the greater tuberosity, not at this point. Okay, so that is also very, very important. If you are doing at radio frequency, you will be doing it close to the radio this tuberosity, not at this point. But if you are going for a local anesthetic steroid block, we can block the axillary nerve at this point at the quadrangular space. So we will be learning the quadrangular space as well. So this part was in the anatomical part. So if you have any questions. So those who are used to, it is not a problem for them. But for those who are new, it may be appear a little difficult. So everyone have understood, or I should do a small recap of the anatomy? Please, you guide me.
Understood, sir.
Okay, fine. So not going further into the details. Rather, let's go for the presentation part and the common pathologies. Okay. So ultrasound of the posterior shoulder. So what are the causes? Same here. Some causes will be musculoskeletal, some causes will be neurological, some coming with the joint pathologies, and referred pain from the other areas like the visceral pain. Similar with the anterior, we have divided into 4 type of causes. Now, if we look at the musculoskeletal causes, first of all, it will come the rotator cuff causes. So what are the rotator cuffs involved there? Definitely the rotator cuff in the posterior side, they are mainly the teres minor and the infraspinatus. So similar like tear, partial tear, tendinitis, tendinopathy, full thickness tear, calcific tendinopathy, everything can possible in the posterior rotator cuff tears as well. Then just I have shown just under the infraspinatus, just under the teres minor, just under the supraspinatus also, we are having the glenoidal labrum. So in case of degenerated conditions or because of the injury, we can have a labral tear, or sometimes we can have a labral cyst as well. So that is one of the common pathology for the posterior shoulder pain. Then there are posterior shoulder instability or subluxation. Sometimes a pain coming from the muscles, which is known as the myofascial pain. Sometimes there could be a muscle strain of the rhomboid trapezius, or sometimes myofascial pain of these muscles also can cause pain. If we come to the neurological signs, The first is the C5 radiculopathy, because when it is the C5 C6 radiculopathy, they can give rise to pain in this area. So it can be confused with the shoulder pain, but actually coming from the neck. Then there is a neurological condition which is known as a suprascapular nerve entrapment that can happen in patients with the backpack carriers, okay, like in military, in school going children. So even those conditions can be prone to develop of a suprascapular nerve entrapment syndrome that gives a neuropathic pain at this area, and these patients can also come with a pain in the posterior shoulder. Then among the joint pathologies, we have the glenohumeral arthritis or shoulder arthritis, simple words, and acromioclavicular arthritis problems in near the posterior part also it can cause pain. So it is in between, it is in the lateral portion. So these are the pains. And then referred pain from the pancreas tumor, or sometimes because of the gallbladder disease or cardiac disease, which are less common but more important. You should not miss these conditions. So let's start with the posterior rotator pathologies, namely the infraspinatus, TD spinous tendinosis, TR calcification. So it's the presentation will be similar, so I'll be going fast. So it is only the location, but rest of everything will remain the same. Causes remains the same, sometimes overuse, sometimes trauma, sometimes because of degenerative changes, sometimes poor mechanics or ergonomics that can actually give rise to this type of pain. So clinical presentation will be presented with the pain in the posterior shoulder, which can radiate down to the arms. Sometimes there could be weakness, and if you ask the patient to do the external rotation, so in the anterior shoulder problem, we have seen that because of the pain in the anterior shoulder and CHL thickening and the adhesive capsulitis, the movement got restricted. But here, the weakness or lag sign may be possible because of the weakness of the infraspinatus and teres minor. Sometimes the patients can have the night pain, and among the tests, we are having the external rotator lag sign. That is for the infraspinatus, we can examine in these conditions. So let us see the infraspinatus under ultrasound. So start with the infraspinatus. Let's show the infraspinatus only. I think it would be better if you show the infraspinatus as well as this
Spinoglenoid notch.
Spinoglenoid. Both we can show
Dig-
together.
dig- dig. হুম? ও বাবা, একে তো আর কি হলো দেখছি। না, এদিকে জানালে হবে না। না না না, এদিকে এদিকে হলে একটু সামনে যা একটু। হ্যাঁ, ওকে।
Okay, now I think you can see the shoulder clearly. So we are starting from the posterior part of the shoulder.
So infraspinatus and the spinoglenoid notch. Okay, so if I put the ultrasound probe here, then I should be seeing the infraspinatus, which is going like this and going to join here in the greater tuberosity. Okay, and below that, what I will see first, in the lateral side, I will see a rounded structure that is the head of humerus. So remember, in while doing the ultrasound here, the finding of a rounded structure is very important. So that is the head of humerus, and after the head of humerus, this side medially, I will find the joint, and then of course the glenoid labrum and glenoidal bone also, and more medially I will see the spinoglenoid notch. So here it is important to find the round structure. Okay, so first I will see the infraspinatus. So I can palpate the scapular spine. So this is the scapular spine. So just below the scapular spine, what I see, that is everything is infraspinatus, nothing else. So here only one important thing is I have to increase the depth a bit. This side, this part is a bit deep. So now what I am seeing, that is the infraspinatus area only. So this is infraspinatus. So if I show you it, okay, increase the gain. So what I can see here. So let's see. So this total muscle, this is the infraspinatus. This part, this is the central tendon. Yeah, central tendon of infraspinatus. Then this is the rounded structure. So what is this? This must be the rounded head of humerus. And then if I can find the rounded structure, this head of humerus, I will of course do a dynamic checking that whether it is head of humerus or not. But I know it is head of humerus, and medially, as soon as you find that this is the head of humerus, then glenoid part should be here. So here I can see some bony area. Okay, so this is the glenoid bone, and this part, this triangle, is the glenoid labrum. Yes. Okay. Labrum, since
Someone is asking a question.
no,
Hello?
coming here, probably insertion point. My video probably.
Okay.
So this is the labrum. Labrum is a fibrocartilage. So ultrasound probe, ultrasound beam will not be stopped here, and I can see this part of the head also. Okay. So again, just see this area. Left side is medial side. Okay. So again, this side, this is the second layer. This is the infraspinatus. Upper, of course, it is deltoid. Upper part is deltoid, and then it is infraspinatus. Then I am going here. Again, I can see a rounded structure. You can see that rounded structure is moving. That means it is head of humerus. So once you have found the head of humerus, you can clearly understand that this triangular structure is nothing but the labrum, and this part is the glenoid bone. You can see this part is completely acoustic shadow is there. That means this is the bony part, and this part is the labrum. Okay, so as we can understand that this part is the joint part actually, then if I come more medially, then this part should be the spinoglenoid notch. Okay, spinoglenoid notch. Spinoglenoid notch is important for what? That is for the suprascapular nerve, to find the suprascapular nerve. But it is like, it is here a bit straight. Okay, I have to make it a bit notch like. So how I will do it? So I will not see like this. I will see from below. Okay, it is, I will see from below, so that it becomes a notch like. Okay, so let's see. Okay, so this is the spinoglenoid notch area. Now I am seeing from a bit below. If I keep it in straight in this way, I mean, in ultrasound, in whichever area you are important, you will focus on that area at that time. So at present I am seeing the glenohumeral joint only. Okay, I am focused in the glenohumeral joint. Now I am coming a bit medially, and I am going to focus in the spinoglenoid notch. So I will see from below, and now I am seeing the spinoglenoid notch. Let me see that whether I can find the vessel or not. So this is the power Doppler. Every time the vessel will come, it is not like that. No. Yeah, it is noise. So it is not taking color at present, but this is the spinoglenoid notch. I can see the pulsatile artery. Actually, you can see the pulsatile artery. Can you see?
Yes, sir.
Yeah, pulsatile artery you can see, but somehow the color it is not taking. We can see with our eye that there is a, I mean, pulsatile artery, but it is not taking color anyway. So you see, I can see, but it is not taking. So this is the spinoglenoid notch, and this part is the joint. So for intervention purpose, if I freeze it, so intervention purpose from posterior side, your so needle should come like this and enter here. Remember, you should not hit the cartilage. just over the bone, over the humeral head, there is a thin layer of cartilage. Okay, so you should not hit the cartilage, and but still you should be below the labrum. So it should come and below the labrum and above the cartilage. Okay. Okay. This part is deltoid. This part is infraspinatus. This is central tendon, as I told. Okay.
Okay. So I hope you have understood this part. This is very important because in a number of procedures we have to see in this view. So one, I have already told, during the shoulder denervation, we can go at this point. If there is a labral cyst, then we have to go to this point. If you want to access the shoulder from the posterior side, remember, even in adhesive capsulitis, the alternative technique, somehow you are not able to do it from the anterior side. Then the older technique was this only, injecting the fluid from the posterior side. So the way Dr. Roy has shown, in the way you have to inject 30 to 40 ml fluid from the posterior side for the distension for the adhesive capsulitis. That was the standard technique before we had started with the this anterior technique. Okay. So what is important here in most of the cases to find out where is any pathology in the labrum or in the joint? So first of all, history, physical examination for the track of tendinitis and to track of tendinopathy related to the teres minor or infraspinatus. We have to check the track of integrity, and definitely MRI or ultrasound. They are the best for the soft tissues. So here we can see a video of the infraspinatus
Insertion point.
tendinosis.
There is some cortical break, and there is a tendinosis. Infraspinatus tendinosis is there. This break is there, and
Okay, there is a small break close to the attachment of the infraspinatus. So basically this patient we have shown have multiple problems actually. So here we are having a complete or full thickness tear of the infraspinatus. So here there is a full thickness tear at this point. Okay, so the it is not visible. Okay, now coming to the management, physical therapy, pharmacotherapy, activity modification, and then we have to go for the injections. If it is a partial tear or tendinopathy, we can go for the platelet-rich plasma injection. If in calcific tendinosis, we can go for the barbotage. In case of needle tenotomy, also possible in case of tendonitis. And sometimes we might have to go for the surgery if it's a full thickness tear or if it is not responding with the other movements. Glenohumeral arthritis is another big problem. So it could be age related. It could be associated with the previous injury or trauma. Sometimes it could be because of the overuse or repetitive activities like the sports or some occupations, or sometimes with the rheumatoid arthritis or systemic inflammatory arthritis that can also give rise to glenohumeral arthritis. Now, glenohumeral arthritis, there should be pain, which is deep, achy pain in the shoulder, sometimes which is worsened by the activity. And here also I have told the stiffness and the pain, they will be persisting together along with the grinding or clicking sign or crepitus, which is associated with the arthritis. There could be range of motion abnormality, mainly the restriction, which will be same in case of active and passive movement, and there could be functional impact in the daily activities like dressing could become difficult, grooming could become difficult. Now coming to the diagnosis, so we have to take the history, pain, stiffness, activity limitation, physical examination for capitas, range of motion, strength, and the joint tenderness. We have to go for the imaging like the X-ray, MRI, CT, ultrasound as required. Now in the management, we can go either for the conservative management at the early stage, NSAIDs, analgesics, pharmacotherapy, and we have to go for the activity modification. Then for the shoulder glenohumeral arthritis, we can go for the corticosteroid injection within the joint from the posterior side. Then sometimes we are also, though the viscous supplementations are mainly for the knee joint, but they are off-label use in for the shoulder arthritis as well, and the result is moderate. And in some cases, the emerging option is the platelet-rich plasma injection, and surgical option remains the arthroscopic or the arthroplasty. Here we are having going for the glenohumeral joint injection. So here we can see this is the labrum portion, this is the humeral head portion. Here is the cartilage. So in between the labrum and cartilage, the needle is being inserted. And definitely as the angle is comparatively steep, so we can see only the tissue movement. Seeing the full needle sometimes is difficult, but you can see and appreciate the needle going at this point. Then we are injecting the local anesthetic and steroid there. Okay, so this is the glenohumeral joint intervention. This is another picture of the same of the glenohumeral joint intervention. So here is the humeral head, here is the glenoidal labrum, and in between this tendon is the tendon of the, anyone say which tendon is this? This tendon, clean cut above tendon,
Infraspinatus.
infraspinatus. Very good. This is the tendon of the infraspinatus, and so we should put our needle in between. So here also this is the needle coming. So yes, here also the angle is steep because this area is a little depth. So sometimes we have to depend on the tissue movement to see where the needle is going. And once we are there, you can see the tip at this point. Then we start injecting within the joint. Okay. Let's move to the labral pathology. So this is the labral and paralabral cyst that might happen close to the labrum. So in these conditions, we sometimes have to go for the aspiration of the cysts and sometimes the corticosteroid injection, which gives a medium to long term benefit for the patients. Cyst in the spinoglenoid notch, that is also possible, and this can cause the shoulder pain because of the compression of the suprascapular nerve as well. But remember, this also can be treated with the aspiration. Next, coming to the suprascapular nerve impingement or neuralgia. So I think now you have already understood that where the suprascapular is. So it is basically a neuropathic condition which leads to the shoulder pain, and sometimes it can cause weakness, especially to the external rotators like the teres minor and the infraspinatus, sometimes the supraspinatus as well, because both are supplied by the subsuprascapular nerve. So coming, it is the anatomy. Origin of the suprascapular nerve is from the C5 C6 roots. Then it travel along with the suprascapular notch under the transverse scapular ligament. Then it goes around the spine of the scapula via the spinoglenoid notch, and then it comes below supplying the infraspinatus, and then it is going to the joint. Common sites of entrapment: one is the suprascapular notch and under the transverse scapular ligament, and another is the spinoglenoid notch. In both the cases, there could be possible pathology and pain at this point. The anatomy I have already shown together with the others. So let's see the etiology and risk factors. So one of the common etiology is the anatomical variant. Sometimes there could be a narrow anatomical space there in the spinoglenoid notch especially, so that can give rise to more chance of suprascapular nerve neuropathy. Next comes to the repetitive overhead activity. The cyst I have shown just now, that's one of the risk factor. One cyst or mass lesion that can actually entrap the suprascapular nerve there, and sometimes that could be inflammation. Okay, so mainly tendinosis, tendinopathy, or inflammation fluid at this area pressing over the suprascapular nerve. So all those possibilities are possible. So there will be pain, deep aching, posterior and in this area. Then there might be weakness because of the supraspinatus and infraspinatus involvement. When the supraspinatus is involved, the overall movement will be difficult. Then when the infraspinatus is more involved, the external rotation will be difficult, and provocative maneuvers like the exacerbated overhead activities or cross body maneuvers, the pain can be reproduced. Physical examination and MRI ultrasound. Remember, in soft tissue pathologies, practically CT and X-ray don't have much role. So most of the cases, the ultrasound you can do the first in the OPD or in the ward, or finally you have to go for the MRI to detect the small things or deeper things. So let's see the ultrasound evaluation of the suprascapular nerve. It's very important, okay? So everyone should learn it because this is the first procedure that we all learned in the posterior shoulder.
So suprascapular nerve, uh, I think you can see. Oh. Yeah. Look at it. Okay, okay. this one. So suprascapular nerve, we want to see the suprascapular nerve in the suprascapular fossa. So difference is, earlier I saw the suprascapular nerve in spinoglenoid fossa. So that is only the sensory branch, but here it is the mixed nerve. Okay, so when I'm just putting the probe here over the scapular spine, so this area is for what? This is for two muscles are there. The upper one, layer 1 is the trapezius, okay, and layer 2 is the supraspinatus. So we can see the supraspinatus central tendon also, but at present we will see the bone below. Okay, so bony margin below. So we will increase the depth a bit so that it becomes clear. Okay, so we are seeing the bone below. So here if I hold like this, then I'm seeing the suprascapular, supraspinous fossa. Okay, I'm seeing the bone of the scapula of the just a minute. Oh, freeze. So I'm seeing the two layer. Okay, trapezius, spinatus. Okay, and this is the bony layer. This bone is the scapula, supraspinatus, supraspinous fossa. Okay, so this side of the scapula. So now what I have to do, I have to see a bit upward. Okay, now I am seeing in the fossa. Now I have to see a bit upward in the margin so that I see a gap here. Okay, and that gap will show the neurovascular bundle covered by a membrane, that is the transverse scapular membrane. Every time this transverse scapular membrane is not very clearly seen, but that is the thing. First I am seeing the bone, so this is the bone. Now I am just moving it in such a way so that I can see the gap. So at present I can see the gap. So can you see in the middle part there is a vessel? Color is very difficult. So we can see actually with our naked eye also we can see that it is pulsating. So what is pulsating here? It doesn't take color. So we can see what is pulsating. It is the suprascapular artery, and of course suprascapular nerve, suprascapular vein, all should be around. We cannot 100% say that okay, this is the suprascapular nerve, because these are very small structures. Okay, but we can see the vessels, and this is the suprascapular fossa, supraspinatus fossa. So it is like this. Okay, this is the artery. This is the artery, and maybe this is the nerve, but this much only you can see. You cannot see 100% with 100% guarantee that okay, this is the nerve. So our first thing is that we will see trapezius and supraspinatus. First we will see the bone, continuous bone like this, and then just see the upper part to the upper margin. I will move like this. Just I will go to the upper margin. I will want to see the upper margin. Then I see the fossa. So in the middle part, you see the pulsatile artery. Okay. So this is the pulsatile artery we can see, and suprascapular nerve also around only. So we have to do some sensory stimulation if there is RF. Otherwise, we can go for the intervention there by block.
Okay, and remember, if you do a radio frequency here, it should always be a pulse radio frequency, not a conventional radio frequency, because we don't want the weakness of the muscles.
Sir, if there is no radio frequency available, then we have to.
Then you have to go for the steroid local anesthetic injection. Usually 2 to 3 ml of dipomethylprednisolone 40 milligram along with 1% lidocaine is most commonly given. And even before the radio frequency, we have done that. And the result is also good. It is not bad. And most important is after the procedure, if it is for the neuropathy only, that means entrapment at that point, then it can go with this fluid only. But if it is happening because of this adhesive capsulitis or because of other shoulder pain you are giving, then actually increases your exercise capability, and also that helps in the reduction of the shoulder pain.
Excuse me,
Thank you.
a quick question.
Yes.
How do you determine which approach to go, either the spinoglenoid or the suprascapular notch?
Yes,
How do you
whenever we are
decide?
very good question. So whenever we are planning, it depends on our planning. Whenever we are planning for a injection, mainly for the neuropathy, then we have to go for the diagnostic block and check what will happen if the entrapment is at the point where above, then the pain relief will not be adequate. Okay. Or if the entrapment is at below, in both the cases, the above the suprascapular nerve block will help. So we have to go for the diagnostic block which to find out where the entrapment is actually happening. Then along with the diagnostic block, most commonly we use the steroid as well to get some therapeutic benefit as well. Okay, so you can go at the both the points, but whenever you are planning for a radiofrequency ablation, in that case you have to be very specific. In that case, if you are going for a cold radiofrequency, you must go for the spinoglenoid notch, not at the suprascapular notch. For the pulse radiofrequency, you can go both the places as it's not causing any motor weakness. All right.
Okay, thank you very much.
Okay, let's continue. So the last part in the management part. So what are the management options for such a condition? First of all, it is the activity modification. Rest, if it is because of the inflammatory cause, NSAIDs will help, as well as the physical therapy helps a lot. Ultrasound guided corticosteroid local anesthetic injection near the suprascapular notch or spinoglenoid notch, depending on the condition, that can reduce the inflammation and pain, and hydrodissection to release the nerve entrapment. It is similar, only increase the volume to around 5 ml. It's a small space, so don't give much. And pulse radiofrequency for the suprascapular nerve, that was the classic approach for a long time. And people get good result in that as well. And surgical intervention is the suprascapular nerve decompression. So here it's a picture for the suprascapular nerve injection. So you have to put the needle. Here also getting the full needle is difficult because it is deep, but you go close to the pulsatile artery and then inject because nerve remains close to it. Usually the needle trajectory should be from the lateral side to medial side under the ultrasound guidance. Now the fluid is being injected at this point. So that is the suprascapular nerve injection. Okay. So it's a very good technique, and here also the success rate is very good. Now coming to the one of the important point, that is the understanding the quadrangular space and axillary nerve branches. So quadrangular space remains at the posterior part, and I am just repeating while the quadrangular space because sometimes it may be a little bit difficult and I have already opened it. So I am just recapping the anatomy. So here lies the quadrangular space, and within the quadrangular space we have the axillary artery. So you can think of like this. There is teres minor, which remains the most superficial and most superior, and just behind or below the teres minor we are having the teres major. And if we go laterally, then we'll be coming to the long head of the triceps. And to understand the long head of the triceps, we'll be find out that in between these two muscles, these fibers are going inside. Then we'll go further lateral towards the neck of the humerus and towards the lateral head of the triceps. And in this position, we'll be getting the artery, which is the circumflex humeral artery, along with the branches of the axillary nerve. So let me come back to the presentation. So let us demonstrate under ultrasound. So we are seeing the posterior side, and here we have to locate in the same manner. That means here we have to locate the infraspinatus and the teres minor in a longitudinal view. So how I am putting the probe? This portion is the index marker. I am putting the index marker towards the superior side. That means towards the head or caudal side, cranial side of the volunteer. So now we are holding the probe in the infraspinatus fossa. So how to understand infraspinatus and supraspinatus? Just cross the, here lies the spine. So if just above the spine it is the supraspinatus fossa, and below it is the cross section of the infraspinatus fossa. Now go below. When we go below, we can distinctly find out two muscles. Okay, so here remains the above muscle, here remains the cross section of the infraspinatus. But as we go down, we can see another muscle here. Okay, it's a small muscle. We can see these small muscles at the center of the skin. This is the teres minor. Now if you go further below, there is another muscle. Okay, so Chinmata, can you point out the third muscle? Yes, this muscle. Huh? So this is the big muscle. It is the teres major. So we have to follow the teres minor and teres major interface, and we have to go to the lateral side. As we are going to the lateral side, we see some fibers from below. They are coming in between these two muscles. Okay, so if we go this side, we can see teres minor and teres major. As we go lateral, we see the fibers of the, kind of point out the, yes, these are the fibers of the long head of the triceps. They are going under the teres minor, and above there is the deltoid. Now as we cross this point, okay, from this area, if here we are having the teres minor, we are following, now we are crossing this area. So once we are crossing this area, we are near the humerus, and at this point we can see artery and vein. So can you see the artery and vein here? Sorry, artery, not only artery, vein, artery and nerve basically. So can you see the movement of the artery? Just below the teres minor. So sometimes it can take color, but not always. Let us try once again. So if it takes, sorry, if it takes color, then it is fine. Again. Oh, it's nice. It's not coming. No, it's not taking color anyway. Just keep it. So these are basically deeper structures. So you might not get color at this point. So at this point, okay, at this point, we can see the branches of the axillary artery and the circumflex humeral artery. So if we have to go for the axillary branch block, especially the local anesthetic block or the steroid local anesthetic block, we can come at this point and we can block just over the shaft of the humerus. Okay, so again I am coming and showing it once again. So first we are finding out the infraspinatus, and then we are finding out the teres minor muscle, and teres major muscle, continuing lateral to find out the long head of the triceps going under the teres minor, and then further going lateral, and where the long head ends and the shaft of the humerus begins, at this point we start seeing the vessels. Okay, so
Sir,
this
can
is
you
the,
point the shaft of humerus here?
yes, the below bone, the hyperictus bone, yes, that part. Okay, over it we can see the vessel, and just by the side of the vessel remains the nerve. Okay, so this part is also very important. That is the ultrasound of the quadrangular space. But remember, the orientation is a little bit difficult. You need a little practice. So In fact, in this course, we try to cover up everything. So sometimes for the new persons, it becomes a little bit difficult. But I would suggest after seeing the video, you just try to see everything in a volunteer. That is the most important learning. Every time you might not get a patient, but getting a volunteer for the shoulder evaluation is very easy. So you see the video once and then try it on a volunteer. And then whenever patient is coming to your OPD, you do the ultrasound for the patient. Or if you're working in a hospital, so if you see such a shoulder problem case and you do the ultrasound in the ward, so that this is a big part of the learning, because in ultrasound, only seeing or knowing the structures is not enough. Basically, you have to do it yourself. So once those who have already registered for the hands-on will be showing here once, but for those who are not registered for the hands-on also, for them also I would suggest in your hospital, wherever you are having the facility of an ultrasound and a volunteer, you just practice. That is one of the most important learning. Now, shoulder denervation is basically a combination of everything. So, three nerves are blocked in the shoulder denervation. Remember, the shoulder denervation technique is not an old technique, it's a comparatively new technique. It is mainly promoted by the Kulif and the Avanos International. So, here what is done, the main technique they have initially described was under the fluoroscopy only, but with the ultrasound, nowadays we take the advantage of the ultrasound. So, basically, shoulder denervation means blocking three nerves. One nerve is definitely the branch of the suprascapular nerve, which is at the spinoglenoid notch. Usually, two cooled radiofrequency lesions are done at this point. The next, the branch of axillary, that is coming to the shoulder. So, near the greater tuberosity, we have to do two lesions. And the third one is at the anterior side. Here lies the lateral pectoral nerve and the branch near the which process is this? Coracoid process. So near the coracoid process we have to block. So basically, as the cooled radio frequency makes a big lesion. Okay. So here if you go just at the middle of the coracoid at this point, it usually covers the nerve, and if you look at the lateral part, we have to look at this point at the branch of the axillary nerve, and here at the level where we have to go for the branch of the suprascapular nerve. So these three nerves needs to be blocked in order to do a shoulder denervation, where actually you want to make the shoulder pain free in such a condition when in any other way you are not able to tackle the shoulder pain. Remember, this is also nowadays a very standard technique and which is done very commonly. So that covers the shoulder ultrasound. Now those who have any questions, they can ask.
Sir, can you show us lateral pectoral nerve?
Yes.
How to detect
See,
lateral pectoral nerve?
these are very small nerves. Under ultrasound, we cannot find out. See, we have seen the coracoid process multiple times, but that small branch is not visible under ultrasound. Okay, so it's based on the position only. It is given.
Please, doctor, you do diagnostic block before doing the frequency. How
Diagnostic
do
block
you
before?
by sun or ultrasound?
Yeah, I think your internet connection is not proper. So can you pardon, please? All
You
right.
do diagnostic block before radio frequency? You do it by C-arm or by ultrasound?
Denervation nowadays we do under ultrasound. Initially, the main technique was initially demonstrated under fluoroscopy only, but here nowadays we do mostly under ultrasound, and if required, we use a hybrid technique of using both.
But you do diagnostic block before or
See, in most of the cases, yes, and in some cases where actually we have to go ultimately for the denervation. So in those cases, sometimes we skip as well. But yes, in most of the cases, we can do a diagnostic blocks first. Okay, I think there is a problem. But before we end today, we have another thing that is also very important. So I am sharing you one page. Please, those who know about the quiz.com, it is fine. But otherwise, I am telling how to join. So it's a very interactive quiz that we do at the end of the class. But in last 2 days we are having too much topics to cover, so we could not complete with this. So I am requesting everyone to just open your browser, that means Chrome or whatever browser you are using, and then write quiz.com. Okay, so everyone have opened the quiz.com? Yes, you started joining. Fine. Now then input the pin, or you can also alternatively scan this QR code. So those who are new especially, just go to the quiz.com and then
Asking Captain Slow.
okay, very good.
House.
Okay, let's start.
Quiz.com. Player Dr. Payne joined.
Which of the following is a
Toilet Pig joined.
Rotator cuff pathology, infraspinatus / teres minor. The primary function of the infraspinatus and teres minor muscles is the external rotation of the humerus. A patient with glenohumeral joint arthritis most likely presents with achy, deep shoulder pain worsened by activity. Needle tenotomy or barbotage is primarily indicated for
Abdullah joined.
calcific tendonitis. The most common site of suprascapular nerve entrapment is at the C. Suprascapular notch. Which two rotator cuff muscles does the suprascapular nerve innervate? The supraspinatus and infraspinatus. Which of the following is not a typical ultrasound guided shoulder procedure? C. Ultrasound guided carpal tunnel release. Carpal tunnel release is typical. Among the following, visceral condition can sometimes refer to pain to the poster. A. Pancreas tumor, lung apex. A primary goal of ultrasound-guided shoulder denervation is C. To disrupt pain transmission from sensory nerves.
Final question. Double points.
In glenohumeral osteoarthritis, which management step is C. Physical therapy and NSAIDs.
Third place. Dr. Woman. Second place. Lucky. And the winner is Foolish House.
So who is the topper today? Foolish House with 10,455 points.
Yay!
Congratulations. Who is this? Okay. Okay, let's end today. And the study material for the whole shoulder we have given. And we are trying to make one more comprehensive with separated anterior and posterior. But you read the whole shoulder study material. It was given together. And the MCQs for this week is also provided. You just complete that and read the explanations as well. So let's end to today. Thank you all for joining.